So the topic, I was asked to talk about heterotaxy, but I usually include situs inversus because we talk about situs abnormalities. First, I would like to define the term situs. The term is used to define the normal or abnormal left-right arrangement of typically asymmetric body organs at three anatomical levels. At the level of the bronchopulmonary system, the atria of the heart, and the abdominal or the visceral arrangement relative to the midline plane, so the left-right orientation of organs. Typically, organ arrangement at any of this anatomical level reflects that of another location. So we call that thoraco-atrial visceral concordance rule, which means if you have a left lung on the left side, you should have a stomach on the left, as an example. So that would be concordant arrangement. It has nothing to do with the position of the heart. So you can have dextrocardia, but still situs solitus. I will come to that later, but still having an abnormal cardiac position is also associated with a significant risk of cardiac abnormalities, as are situs abnormalities. This is what we call viscerator concordance. So situs solitus is the usual arrangement in the vast majority of people, where you have at abdominal level a liver mainly on the right side, the stomach on the left, and the spleen on the left. And the gut is normally rotated. The heart is typically pointed to the left, but it has, as I mentioned, nothing to do with the situs, so it could be on the other side. You have an IVC that's typically on the right, an aorta that descends typically on the left, and a left lung on the left and the right lung on the right. Situs inversus is just a mirror image of the organs. It doesn't necessarily mean you have an abnormality of the heart in this situation. I will come to that, but it's just mirror imaging. Now there are conditions we call heterotaxy, where you have neither solitus nor inversus arrangement of these organs, and we call this also, or some call it situs ambiguous, but this is what we call heterotaxy or isomerism. With the right isomerism, you have typically, if you look here, the right lung, I didn't mention this, so the bronchial system on the right, which you don't see prenatally really unless you're a perfect scanner, but the right bronchus is short and the left one is much longer. That's one of the difference. The right lung has 3 lobes. Again, you can't see that before birth. It's more after birth that we look at this. So if you have right isomerism, you have 2 right lungs, one on the left and one on the other on the right, with the typical branching pattern of the trachea of a right bronchial system. You have atrial appendages that are right, and you have a more midline. You have a midline liver, and the stomach is typically more midline compared to the other system. It can be on the right or on the left, but it's more midline. And typically there is asplenia. With the left isomerism, you do have long bronchi, and the heart can be on the right or on the left. You have 2 left atrial appendages, and you have also a midline liver, but it's a little bit less symmetric, so it's predominant on one side. Again, the stomach more in the middle, on the right or on the left, but you have polysplenia. That's classic. So let's look at the thoracic situs, which I just mentioned. This is something we don't look before birth, so you don't really need to bother about it, but it's very helpful after birth because we do X-ray and we look how the bronchi look like. So this is the situs solitus with a long left-sided bronchus. Here, situs inversus, where the right sided bronchus is long because that's the left lung, and this is the right lung. In right isomerism, where you have the pattern with short bronchi, and the left isomerism is relatively symmetric with long bronchi. So we use that after birth on X-rays. Now the atrial situs is very important, and the definition of atrial is determined according to the Anderson definition based on the morphology of the atrial appendages. The right atrial appendage is broad-based, it's shown here, that's the right atrial appendage, and is filled with pectinate muscle. You can see that sometimes before birth if you look at it, but most of the time you will not be able to look at this as well. So again, a difficult diagnosis to say if this is really right appendage or not in utero. The left atrial appendage is more finger-like. It has far less pectinate muscle, and it has a complete different shape. So now you have, based on this, what I told you, with the usual arrangement, so situs solitus, situs inversus, you have the typical arrangement, right atrium on the right here with solitus, and the left atrial appendage on the left, inverted. Then with right isomerism, you do have two right atrial appendages, and the connection is in this situation, if these are two right atria and goes to the ventricle, it's not a concordant connection between atrioventricle. It is ambiguous because you have two right atria that goes one to the left ventricle and one to the right ventricle. Same thing with the left atrial isomerism, where you have two morphologic left atria, but they go to on one side to a right or left ventricle. These are two examples. This one I know is a right isomerism because he has all other features, but frankly I would not, just looking at the atrial appendage, and say these are two right atrial appendages, and this one more finger-like here, left atrial appendages. So I'm always biased when I look at this and think that fits to my opinion that I have already made. So the visceral situs, as I mentioned, this is the usual arrangement with liver on the right side, stomach on the left, and the spleen inverted, and midline liver, like shown here. The stomach is more in the middle, and it can be on the right or left, and I will show examples. And in left isomerism, the liver is also spanning the whole width of the abdomen, but it's usually larger at one place. So here on the right side, then rather on the left side, and the stomach again displaced, and there are multiple spleens. So why is this important that we determine the situs? With situs solitus on levocardia, that's what we usually have. The risk of having a cardiac abnormality is less than 1%. So that's quite reassuring already when you do a scan and you know it's situs solitus. If it's situs solitus and dextrocardia, so no situs abnormality, but the heart on the wrong side, you have more than 90% chance that that baby has a heart defect. If you have an abnormal situs, a situs inversus, and the heart is on the left, more than 95%. Situs inversus with dextrocardia, so just a mirror image, still a risk of 10 to 50% that you will find a cardiac abnormality. Right isomerism, I've never seen a right isomerism without cardiac abnormalities, and they're always severe. So I've never seen a mild form of cardiac defects with right isomerism. Left isomerism, most do have some sort of structural heart disease, but this is highly variable. It can range from an interrupted IVC to left atria with a slower heart rhythm, and otherwise normal findings to abnormalities that are in the severe spectrum, like the right isomerism with single ventricles. So the first thing you should be doing always, I think, when you do a scan, you determine what's right and left and of the fetus. And then you start with a scan from the upper abdomen, assess the position of the inferior vena cava, descending aorta, the stomach and the liver. Then you scroll up the transducer to the four-chamber view, trace the inferior vena cava to make sure it's connected properly to the right atrium. And how we are doing this, or how can you do this? Now, I work in a lab where we have technicians, fellows doing it, and I need to rely that they display me when I review it in a proper way, so I'm sure what is right and left without me touching the probe. What we do is we displace the fetus in a transverse lie with the head here, and then turn the probe 90 degrees clockwise, and you will always get a 4-chamber view. And this 4-chamber view is looking from the button up to the head. So this is left, if this is the spine. So that's the way we display it. And this was published many, many years ago by Cordis and colleagues, and is used routinely in our lab. And there's no doubt, if this is done properly, what is right or left, unless somebody turns the probe in the wrong direction, then you get it wrong. So when the spine is here, left will be here, right here. If the spine is up, left will be here, so it's just rotated. Very simple way, very reproducible. And then we scan obviously up into different plates to 4-chamber view, 3-vessel view, and there are other views we will get as well, obviously. So this is an example to what I just explained. So head was on the right, we turn it clockwise, the spine is here, the heart is pointing to the left, the stomach is on the left, the descent aorta is on the left, the aortic arch is on the left, echo is done, 2 minutes. Okay, if a baby behaves, it's actually true. So again, showing the same image at the abdominal level, stomach here, descent aorta on the left, and you see actually the IVC draining into the right-sided atrium. So this is shown here. So aorta here, and some distance, the inferior vena cava, and the stomach on the same side as the heart points on the left. One thing that was mentioned before is looking at the heart position and axis and size. The position should be midline, apex to the left. If you have hyperplasia, as an example of the left lung, and the heart is shifted more left, we call this levo position, and not necessarily, or the other side, you have no right lung, and the heart is now shifted to the right. We call this dextro position of the heart, and not dextrocardia. So if it's still pointing to the left. So we look what the heart axis is, and then we describe it as levocardia, mesocardia, dextrocardia, unless it's not in the right position. And then we describe it slightly different. So, as I mentioned, levocardia with situs solitus, structural heart disease risk less than 1%. So I show you a case. Same thing, head on the right, we turn clockwise, and seems to be a structurally normal heart with nice crossing over of the great arteries. 3-vessel view looks normal. Now, as I mentioned, if we do this according to Cordis, this heart is pointing in the wrong direction. So it's dextrocardia. The descent aorta is on the right, and everything is flipped. So stomach down here. So complete mirror image. I've seen a number of times this was not diagnosed before and came to us, and we told them it's situs inversus. So because somebody got confused just with the situs assessment, but if you do routinely the one method I explain you should not miss this. So situs inversus, what this baby had, is not common, 1 in 10,000 live birth. It can have an autosomal recessive inheritance, structural heart disease, relatively low risk if it's dextrocardia, very high if it's levocardia. There's an association with immotile cilia syndrome in 25%, which leads to chronic respiratory infections after birth, with chronic lung infections, bronchiectasia, chronic ear infections, and male infertility. So that's one of the things we usually will counsel families about and do testing, genetic testing after birth or before birth if parents want to know that. So let's talk about heterotaxy syndromes. It's somewhat more common than the situs inversus. Left isomerism is more common than right isomerism. And there are probably a number of patients with left isomerism we actually don't diagnose because they are fine. And I had a patient with complete situs inversus not diagnosed until 7 years of age that had the trauma, and then they did an X-ray and found the heart on the wrong side. So it's not unusual to have abnormalities that you're not aware of. Maybe one here has left isomerism of you without anything else, so we never know. But there is 4% of infants with structural heart disease, so it's not so rare. There are single gene defects reported, and there's some familiar forms. So the right isomerism or bilateral right-sidedness has a right bronchopulmonary pattern, as I told you, right atrial appendages, asplenia, because spleens are a left-sided structure, so you end up usually with asplenia, and cardiac defects in 100%. And this is on the left side, we would have polysplenia. Cardiac defects are common, but are not necessarily there. Now, this is the classic pattern, and Shi-Jun Yu, who works at my institution, and Diane, they were looking at the data after birth, how reliable this concordance rule really is. And it's true in 80% of cases, but there was a breaching of the general rules of heterotaxy in 21%. So you can have situs solitus at abdominal level, but still isomerism at thoracic level. And so it's not absolutely, as a rule, that is true. Does not necessarily impact your management, but it is quite important. If you don't think that everything fits completely together, don't be surprised, that might be true. So there are differences between right and left isomerism. Bilateral SVC, very common in both. You will not be able to use that diagnostically. Also, the SVC usually drains just in the atrium. There's no coronary sinus. So you see just drainage to an atrium without a coronary sinus, typically in right isomerism. IVC interruption is a key feature of left isomerism with acicus continuation. So the intrahepatic part of the IVC is interrupted. Juxtaposed aorta and IVC, which means the aorta is posterior, the IVC in front on the same side, is a classic feature of right isomerism. Extracardiac TAPVC, very common with right isomerism, very rare with left. AVSDs is unfortunately common in both conditions, but the right isomerism is always unbalanced and significantly unbalanced, so which complicates the repair of this condition after birth. Then because of this situation that they're mainly unbalanced, univentricular repair is the usual outcome of right isomerism, why you can fix the left isomerism in most patients. The great artery are discordant, so transposed with right isomerism, but concordant with left isomerism. Right isomerism with an anterior aorta and a posterior pulmonary artery is almost always severely stenotic or even atretic. That's rare in left isomerism, but they tend to have left obstruction, so coarctation, aortic atresia, or aortic stenosis. Complete heart block is not a feature of right isomerism, but of left isomerism. I think the 25% are probably overestimated, but it's also not true that patients with left isomerism are necessarily at risk. It's only the patients that have AVSDs. So you don't need to be afraid if you don't have an AVSD that the patient will suddenly come back with complete heart block. It's not happening. Then this is a condition we always counsel. So the non-cardiac abnormalities, right isomerism, left isomerism, they have intestinal malrotation. Doesn't necessarily mean that there will be a complication about this, but the gut is not normally oriented and rotated. You can have hernias with right isomerism, biliary atresia you have with left isomerism, and that's always important to counsel as well, because biliary atresia means potentially even a liver transplant if you are very unlucky, but needs a surgery after birth. Duodenal atresia, urinary tract abnormalities, so significant number of non-cardiac abnormalities with left isomerism of the rear with right. So let's show you some examples. So this is a patient with right isomerism, and this is on this fetus. I didn't display it, but this is the right side. So we have rotated, and what you see already, this is an unbalanced AVSD. There's a small ventricle on the right side and a bigger one on the left. And the AV valve almost exclusively goes towards one ventricle. Another key feature that you see in right isomerism is this dot in the center. We call this a dot sign. It's related to a strand of tissue that runs across the atrium. This plays in the four-chamber view as a round circle. In this one, the stomach is here. On the right side, that's the aorta, and this is actually the juxtaposed IVC. So not interrupted, but on the wrong position. So an unbalanced AVC combination with a dot sign, and here I labeled it, so the aorta, IVC, and the stomach, and the liver is transverse, spans the whole tummy. And histologically, the strand sign looks like this. So this is just a remnant of tissue that separates, the bar of muscle that separates, that runs across the whole atrium, and is displayed if you look at this plane as a circle. So this is another case, also with an unbalanced AVSD, dot sign. The stomach is on the other side here, again juxtaposed, vessels at abdominal level. As I mentioned, with right isomerism, the great arteries tend to be malposed, and here is the aorta here with the neck vessel, and posterior is the pulmonary artery, and the pulmonary artery is stenotic. You have flow reversal through the duct. So an unbalanced AVC with anterior aorta, posterior pulmonary artery, that's stenotic, typical for right isomerism. There's an IVC training here to the right atrium, but you probably see the structure behind, and this structure is actually the pulmonary venous drainage that goes down into the liver and is not connected. So a fetus that has, which is shown here, so don't get fooled if the pulmonary veins look like they will go to the heart. In this situation, they run down here, vertical vein, and then join here into the liver. So TAPVC infradiaphragmatic. And if you Doppler it, it has a continuous flow pattern, and you can bet at birth this will be obstructive because you have far more blood flow going through the lungs after birth, and this usually needs surgery rapidly. So that's a high-risk patient population. I have another one here that shows the drainage into the liver. And if it's severely obstructive, and that's the next concern, you end up with lymphangiectasia, and the patient actually has severe lung disease and is inoperable, like this one. So clues to right isomerism, abdominal aorta behind the IVC on the same side of the spine, what we call juxtaposition, a symmetric liver, stomach on either side but closer to the midline, common atrium with a central dot or strand, and the typical anatomical feature, unbalanced AVC, anterior aorta, and posterior pulmonary artery. Left isomerism can look like this. completely normal looking heart, or severely abnormal heart, an AVSD, with some cardiac arrhythmia. But they have something in common, and that's anterior aorta and posterior, more posterior, the azygos vein. So you see two circles typically with the aorta anterior and the azygos vein more posterior. In the sagittal plane, you will not see an IVC, and then you can actually see here the descending aorta, and on the other way, the flow up is the azygos vein just behind. So if you see two vessels just behind, and this vessel is large, you can be sure it's an azygos vein drainage. Here we follow it. So again, pointed out, this is short axis view. So we go up and we see it's actually entering the SVC, and we can also do MRI if you want to, but it's usually, we actually do it because we would like to have more information about the lungs if we have TAPVC, if there is any signs of lymphangiectasia before birth. This is the worst spectrum you can see in utero: non-balanced AVC with very abnormal looking myocardium, severe AV valve regurgitation, and very abnormal slow heart rate. And again, you have two vessels here, which were the azygos vein and the descending aorta. This is what we would like to see, or we will see in these patients: drainage of the azygos vein into the SVC. This patient had the worst complication you can have in this group before birth: complete heart block. With severe prognosis. Few survivors with that. If you see it, whatever you do, you can try to speed up the heart rate, and even heart rate at 70 beats per minute are not tolerated usually. It's a single ventricular physiology most of the time in these patients. And something else with complete heart block, with left isomerism, you often see is spongy myocardium. As you can see here, that's a complete abnormal myocardium. That's a very well known association with left isomerism, complete heart block, and it's a spongy myocardium. So the atrial rate is usually also slower in left isomerism because there are two left atria. There's not a normal sinus node, but they're usually in the range about 110, 120. They're not extremely slow, and the ventricular rate is usually less than 65, and that's the end stage. What we usually see: wall-to-wall heart, high drops, very abnormal looking myocardium. That's, as I mentioned, spongy, and these babies usually don't make it to delivery. And if you see, often you see complete heart block already at 12, 14 weeks of gestation in this patient. So the first time this becomes noticed that there's a problem is often because of the bradycardia at that stage. So polysplenia belongs to left isomerism. I'm not looking at spleens, but you can see them in short axis. But I'm not very good in telling if they're polysplenia or single spleen, to be honest. They have an asymmetric midline liver and malrotation of the gut. And this is a patient I just actually seen last month with a left isomerism. And I'm not supposed to see that before birth, and I can't recall I have seen it before. But this is a patient who was seen 2 weeks earlier with a normal-looking gut, and this is volvulus. So this patient actually had malrotation and twisted the midgut and required delivery and emergent surgery for that condition. So if you see something like that with left isomerism, be aware this could be obstruction that has just developed, like in this case. So clues to left isomerism: IVC interruption, two larger vessels in front of the spine. The posterior one is the azygos vein, the anterior, you see a pulsatile, is the aorta. A less symmetric liver, multiple spleens, most have polysplenia. You can have the combination too, with both. That you can have asplenia with left isomerism, and you can have polysplenia with right isomerism too. But most of the time that's true. You have multiple spleens. Stomachs can be on either side, but closer to midline. And then atrial bradycardia belongs to this. There are slower heart rates, and it might be followed by complete heart block. When we were looking at the outcome of patients some years ago with right isomerism, left isomerism, as you can see, we had more left. This was our survival curve, and I don't think this has necessarily changed. What has changed is that this kept picked up before birth now, but the left isomerism patients have a far better prognosis than the right. We had 10% survival after fetal diagnosis of right isomerism. So in summary, there's a strong association between abnormal-situs and congenital heart disease. Left atrial isomerism compared with right isomerism has a higher risk of in utero demise due to high degree AV block. Clinically relevant extracardiac defects like biliary atresia, or like I showed you, the malrotation is usually left. The right, strangely, they don't malrotate. Severe cardiac abnormalities belong to the right isomerism. Bivy repair is common with left, but pretty unlikely with right. And the postnatal survival rate is also much better with left isomerism than with right. Thank you very much.